Good evening. Welcome to tonight's ASES Virtual Fellow Conference. This is a 16-week virtual program under the auspices and leadership of our president, Dr. Bill Levine. Tonight's session is pasta lesions and what to do in athletes. Our moderator is Dr. Patrick Denard. Our panelists are Sarah Edwards, David Glaser, and Edwin Spencer. Please feel free to ask questions. They'll be brought to our panelists, and we look forward to an exciting, engaging session. Pat?
All right. Well, we got to thank our sponsor, DJO, for this event, and thanks to Dr. Gupa and Dr. Mazaka for putting together a great program, letting us be a part of this. I have a good panel for you tonight. Dr. Spencer from Knoxville, Tennessee, Dr. Edwards from San Francisco, and Dr. Glaser from Pennsylvania. So we're going to try to make this as interactive as possible. If you guys don't interrupt me, I think they're going to interrupt me because we want to kind of go back and forth and hear what everybody's doing and learn. So first case, we got a 22-year-old college baseball player. He's an infielder. He's had a right shoulder pain. It's his dominant arm with throwing for about 6 months. And he's got a normal exam. I didn't see him at this time because this is several years ago, but here's his MRI. And you can see he's got a partial tear here. So Sarah, you treat a lot of athletes. What's your first approach to a guy like this?
Well, he's a young baseball player, so I would be concerned. Is this his dominant side, you said?
It's his dominant arm. Yep, he's an infielder.
Yeah, so on exam, I'd want to know what his range of motion was and if it was normal, and see if he had any evidence of GERD. I'd be looking for an internal rotation deficit.
Great. Yeah. Okay. So he was seen a long time ago. This is 10 years ago. He was treated conservatively. He actually did well. I think just one of the things that brings up for me asking is, how common do you guys see this find in the general population? You know, pasta tears, and specifically in athletes. Spencer, treat a lot of shoulders. Tell me what do you tell patients when they come in? They got, hey doc, I got a tear in my rotator cuff. I got to do something about this.
Go ahead and go back to that.
You betcha.
Are you calling that an articular sided tear, or is that an intra-substance tear? A little grainy, it's hard to tell, but
it is hard. It's, you know, this is an old one. This is 10 years back here. To me, it looks like he's got an intra-substance tear.
Almost. Yeah.
Can you point it out with your with pointer, please?
We'll play one more time. I'll show you right here. My cursor, he's got just a little bit of an intra-substance tear there.
Yeah, you can see it a little bit more, like one more click right there.
Mm-hmm. Yeah, it kind of goes obliquely.
Right. So I agree exactly what Sarah was saying. You check the range of motion, make sure their total arc is at least a good 170 degrees, and that should be shifted externally. But one of the other things is really checking the scapula. Is something I learned from Ben Kibler, who's taken care of a lot of throwing athletes. There's a lot of these partial tears that are more symptomatic, labral tears that are more symptomatic because they have a thick scapula. And focus on that as well as core strength and exercises. You'll find a lot of you guys hear some background?
Yeah, I do.
You'll find a lot of these athletes. These are mainly the high school athletes and not the D1 pitchers, but some of the other 2,
Hey, Ed.
3
Ed.
pitchers, maybe not getting as much attention. Their core strength. Yeah.
Ed, we're having some audio problems. Do you have a headset by chance?
I don't. I've got some earbuds. I don't know if that would help. I don't have a headset though.
Okay. I don't know if you want to speak.
It's all good. Well, I mean, I can summarize, Bill, there. I mean, basically what I caught Ed saying was just backing up what Sarah said. You want to really, on these athletes, think about internal rotation deficit, check their scapula, And we're going to start conservatively first. Okay, so in terms of incidence here, let's say, first of all, throwing athletes, how common are we? I mean, how often are you guys seeing these in your throwing athletes, overhead athletes?
It's extremely common. You're going to see, rotator cuff injuries in about 40% is what the studies show.
Yeah.
So, and again, you want to do everything you can not to operate on them. So,
Yep.
a lot of it's education, just telling them, explaining that to them, that it's super common and that
Right.
most of them will not need any kind of surgery.
That's actually the exact thing I'm just trying to reiterate here. We know, we got this study here from years ago out of Miami by Cher, classic study, looked at age breakdowns, kind of increasing in incidence, about 4%, 40 to 60, and 25% over the age of 60. So many of these are age related, but particularly when we are in our athletic population, we have a high percentage. Sarah nailed that number there. Pat Connor's study back in 2013, 40% of athletes have partial tears. So it's normal in this population, and we got to look at all the causes first. So at this time, he gets treated conservatively. We talked about making sure he maximizes internal rotation and maximizing his core strength, scapular coordination. He goes and does that. He does well. He comes back 12 years later. Now he's a high school coach, so he's still playing some baseball, throwing a lot. He's one of the small schools around here. He's got anterior shoulder pain, bothering him when throwing and sleeping. He's done a little bit of therapy, not a ton, but a little bit of therapy. This is exam here. He's got normal motion, and he has some good strength in infra. He's got some pain with supra and positive Hawkins maneuver. So here's his x-rays here. Any comments here? Not too much. Okay, I'll move on. I'll show his MRI. And Dave, I'll let you comment on this one. Tell me what you think about his MRI now compared to previous.
Well, his MRI scan shows that the tear looks like it's progressed a bit. But you probably don't have any other axial shots of that MRI. I'm looking at I caught a glimpse of his posterior inferior labrum when you flip by it a few times, and the real question is what is the source for his pain? So so right down in there. So the question is there a little bit of, and if you go back and look at the X-rays again, is there a little mild glenoid dysplasia here as well? So is that, again, it's hard to say on that X-ray, but I don't think so. But it all goes back down to exam, and what's the exam like? Does he display internal glenoid impingement versus pain when you specifically test the rotator cuff? So I spent a lot of time trying to test the rotator cuff and distinguish from an impingement, internal impingement versus a primary cuff issue. And
so, okay, you brought that up, internal impingement. Walk us through how you are going to distinguish that.
Well, you go through a standard, first off, you check the range of motion, obviously, and you look at scapular mechanics, you check his passive motion, make sure the passive motion is full. And then you start performing several tests to test strength of the cuff and try to predict, based upon strength testing alone, how much pain they have. And then you can do provocative positioning. And I look at the ratio of pain. So some patients are not that painful when you're testing them. But then if you check them in certain positions, especially provocative, like a Mayer shear test, they are much more painful. So those individuals, if they have that very sharp end pain, end motion pain, you can grind them across the glenoid. That's more mechanical internal impingement versus just they're overthrowing and they have this intrinsic cuff disease and they fail their cuff because they're just throwing too much and decelerating too much.
Mm-hmm. Ed, were you going to say something? No? Okay. So here's his MRI. He's progressed. What would you guys do now with him? Let's say we've evaluated the labrum. We feel like his labrum's normal. We feel like this is a cuff issue. We're in a POSTA conference. I think those are great issues we brought up, but what are you going to do at this point?
At this point, he's 30 years old. Is that correct?
Yeah, he's mid 34.
Okay. So, I'm going to do again, on the physical exam, I want to assess, does he have any micro instability that's contributing? So similar to what David said. Um, And then I would consider a selective injection in him at that point, potentially trying to discern what's going on. His high grade, his partial tear looks very high grade, so I agree it's concerning. I don't think you have to jump to surgery right away. You could still try rehab on him one more time. But
that's what I did. I told him, hey, he's like, I'm throwing this summer. I'm going to try to coach my players this summer. And he's like, just get me back to play. So I did an injection just to cool him down. But this is, I think, he's probably going to come to surgery. But what do you guys tell him about risk of progression? Because now we got a guy who's, he's progressed over 12 years. He's gone from some intrasubstance to more substantial tear. Are you going to tell him to come back? Are you just going to say, hey, are you going to MRI him again? I just want to hear what you guys would do with that.
Are you doing ultrasound guided injections, Pat, and Sarah, when you guys are talking about injections?
I do.
I do not.
I do.
David?
You do, Ed?
I do not. But in this guy, I may. So in patients who I'm not sure about the diagnosis, and I'm doing it for a diagnosis purpose, if it needs to be a glenohumeral joint injection, I want to be absolutely sure that's in there. So I'll send him to someone else to do the ultrasound guided injection. But if I'm sure of the pathology, then I'll do the injection myself in the office, and then I'll look for the predicted response. And if the predicted response is correct, then I'm assuming I got the right spot.
No, that's
where are we going with? Where would you inject him, Spencer?
I would do an ultrasound guided subacromial injection, but I also talked to him about a PRP injection. But to answer your question about risk, I think the data is 30% of them progress over a 3-year period. The partial thickness cuff tears do, an ultrasound study. So, I mean, it's definitely going to progress, but it's not going to get to the point where it's irreparable. So I tell them you can tough this out as long as you want. But we've done. Is my audio working now?
Yeah, you're good. So do you tell them to come back in 6 months, a year, 2 years?
No.
What do you tell them to do? Just follow pain?
Yeah. When it gets bad enough, you'll come back in and see us. Yeah, I'll let them make the decision.
I actually will tell them to come back in a year. I like to scan them a year later and follow that. If now I'm following those out routinely. If I see someone with that high grade of a tear, I'll tell them I want to see him back and make sure it's not getting worse.
Yeah, I agree with Sarah. So for this, I judge my follow-up MRI studies on my concern level for this type of tear that the person has. So a partial tear, I'll go out easily a year. That's not a problem. But if it's getting to be a full thickness tear and it's of concern when it comes to age group, then that might even be a 6 month or even sometimes even a 3 month. So if someone has a full thickness, full width tear at risk, and they just for whatever reason don't want to get it fixed, I'd watch that even more closely.
Yeah. What do you tell? Okay, so they come back in a year and it's gotten 50% bigger. What do you tell them then?
Well, I don't really tell them anything. I tell them it's 50% bigger and kind of let them decide. It's always a really tough sell to have someone who's completely asymptomatic and you tell them that their tear is getting larger. And that's I tell them at this point, I can only make you worse with surgery. I can't make you better because you're functionally great. But then I talk about natural history. We've got some work done at Penn talking about joint destruction and cuff tears, and Lou Kozlowski's published several papers on that. So I just have to tell them that there's an issue with tears over time. We don't really know all the data, but they need to make the decision because, in our current world, there are people that will hold us responsible for kind of putting our heads in the sand and kind of ignoring something that we think could progress.
But the conversation really hasn't changed for you, though. It's just a year later, and he's like, "Doc, I paid for another MRI, and you're telling me the same thing, right?"
Yeah.
Doc, do you own this MRI scanner?
Yeah. So, so I kind of, I'll just bring bring it 50-50. I go with Ed. I follow pain. I tell them you're going to progress. We know this is going to go on to a full thickness tear eventually. It's just a matter of when. And I use pain as a guide. Pain's not a perfect guide, but Keener had his study a few years ago that showed that pain was related to progression. Just a couple of just quick reviews here. Partial tears progress slowly. Aman's study, 90% had no change in 2 years. If you go to Keener's study, 5 years, 56 partial tears. 44 of them progressed over that time, a median follow-up of 3.3 years. And I think this is interesting data for the fellows out there to think about survival. So 2 years, it's about 90%, but somewhere between the 2 and 5 years, it starts to drop 65% in terms of progressing to a full thickness tear. So that's a good number to keep in mind when you're talking to these patients. It's not an urgency, but something that they will have to address eventually. And just similar findings here from Korea as well. These slow progression rates. And most of these, fortunately, they don't have this atrophy progression because they go to get to a full thickness tear first. Now, what if these were his x-rays on the left? What if the guy comes in with these x-rays on the right and he's got the same tear? Does it change anything you do?
It doesn't for me.
No.
Spencer? David?
No.
Nothing? No? So I guess what I was hoping I could get somebody to maybe bite on is we know increased CSA is associated with cuff tears. Does anybody believe that if that's the case, can we prevent it if we get to it earlier? If you get to maybe an intermediate grade tear, can you do a decompression earlier on and prevent this from going on?
So you think the decompression you think the acromial impingement is causative?
Well, if in general, if you think that increased CSA is associated with rotator cuff tears, right?
Yeah.
If you buy that, if you believe in that data, would you surmise that you could catch one of these earlier, do a decompression and prevent it from becoming a bigger problem? And or do you look at this and think, okay, he's at higher risk of progression, and you decide you're going to say, intervene now?
There's really no basis to consider that, and also if you really go back and look at Andrew Carr's work from Oxford, he had that great prospective blinded study with placebo surgery for decompressions and, showed no difference in outcome. Slightly different question, but I don't think we have any. I hope most people don't just do lateral acromiectomies just to try to change the critical shoulder angle. I'm not sure if that's been published. There was some guy in Philadelphia years and years ago who used to do a acromiectomy completely for impingement. So I hope we're not going down that road.
Yeah, totally agree with you. There's no data. I think it's just interesting to think about. And of course, Carr, they're looking at. I don't believe they were looking at lateral bevels. They were looking at more acromioplasty in a traditional manner, correct?
Yeah, that's just traditional acromioplasty. Yeah.
Yeah.
But they didn't talk about
it's something
CSA
that,
or anything.
Let me ask you this: when you all have a partial cuff tear or a cuff tear in general, and you have a CSA like this, are you doing a lateral bevel, or do you leave it? Ed?
You're essentially asking us what we do intraoperatively
with the acromion.
Yeah.
If you have one on the right like this, he's got an increased CSA. Do you do a lateral bevel, or do you just do your repair and say, okay, if data shows acromioplasty doesn't make a difference, and leave it at that?
It honestly depends on whether I actually physically see impingement. If it looks like the CA ligament is frayed, then I'll do an acromioplasty. But if it doesn't look like the CA ligament's involved, then I don't do a decompression or acromioplasty.
So, but hey, when you say that, you're talking about the anterior acromion, right? I'm talking about lateral bevel on the side. Do you do anything there?
If there's hypertrophy there and it looks like that there's bursal thickening or fraying there, then I will. But I really have to see a physical sign that there is impingement there before I'll mess with that. So I don't buy into you've got to bevel that out if you see this increase in the critical shoulder angle.
Sarah, anything different?
No, I agree. I'll often do just the anterior leading edge, but not the entire acromion.
I think an important take-home message for the fellows is that you should not have one way to approach the acromion. There's enough data now that says you don't ever need to do an acromioplasty, but then if you look at the subgroup, some people go back and have acromioplasty. So if we were able to use intraoperative data and then select who gets acromioplasties, I think we would have much more consistent findings.
Absolutely, I fully agree. And of course, the data on lateral acromion is still evolving. We know it's associated with cuff tears. There's some stuff that suggested re-tear, but we can't, that's not great data, and we don't know that you can prevent anything. So something that's going to continue to evolve, I think. So, all right.
Though, Pat, can you go back to that intra-substance cuff tear? So
Yeah.
we submitted a paper to AJS.
Wait for that. Wait for that. I'm gonna get to what you're getting at. Hopefully, we're gonna finally get to maybe do something operative here, and I want to talk about exactly what you're talking about. So, this is a 65-year-old gentleman. He's got left shoulder pain for 6 months. He's rancher, very active. Tried anti-inflammatories, cuff strengthening injection. Subductor shoulder value is 30%. You see he's got full motion. He's weak in external rotation and supraspinatus strength. He's got positive impingement findings on exam. And here are his x-rays. I think pretty straightforward here. No significant arthritis. Well-centered. Here's his MRI. Just snapshots are all I have here. I don't have the video. So I know it's a little tough to see on the single shot. So I'll lead into what I'm seeing here is he's got a partial articular-sided tear of the supraspinatus tendon. And then I think he has quite a bit of edema in his infraspinatus view and his coronal view here. Sagittal views, T1, he's got a little bit of atrophy of his supraspinatus. Maybe some of his teres minor as well, and then some of his edema, again, on the infraspinatus. So, Sarah, how would you treat this guy? First of all, let me ask, what do you consider adequate conservative treatment in a partial cuff tear?
I usually
what's your kind of
3 to 6 months, and if they're still complaining of pain at that point, then consider operative treatment for them. So 3 to 6 months is usually, I'll tell them to go to therapy for a period of time. So, and sorry, go ahead.
Say again.
No, I would recommend they go to physical therapy, potentially give an injection during that time. Right.
How many injections will you do now? And has your amount of injections you do changed?
Yeah, I usually will only do 2 and then I'm done. And there's really no data behind that other than we know that by continuing to give them now that we're potentially weakening the tendon and making the surgery have a higher risk of infection down the road or a higher risk of failure of the cuff repair. So I worry about it. So it's concerning, but I usually will give 2 max.
Up to 2.
Yeah.
Brian Werner had a database study, a couple of years ago, Medicare data, large patients, so it took a lot to find it, but in his study, if you did an injection within a year prior to surgery, you're okay. If you did 2, you raised the risk of revision. But they were small numbers. I mean, stuff that would be really hard to even pick up in our practice, large databases. So treatment on this gentleman now, he's done therapy, injection, how would you go about it?
So he's already done that, you said? He's finished?
Yeah, he has. He's
so
failed.
Then, I would plan on an arthroscopic repair, or I tell him it's a possible rotator cuff repair, consent him to everything, explain, the differences in the rehab afterward, but kind of plan on doing everything if we needed, but also potentially a debridement.
Gotcha. So Ed, what about his edema?
Yeah,
that's do anything about it?
Is that edema from an injection? You think he has denervation edema? I'd get an electrodiagnostic study to see if he's got compression of the superscapular nerve at the base of the spine, scapular spine. I think that's less, I see it more commonly in younger patients. Older patients, it's because he's got a retracted superscapular. But I'd want to get that data before I go into it.
What if the study's positive, fine, he's got suprascapular neuropathy. What if the study's negative?
Yeah, that's a really good question. I've done enough of them where I'm confident, and you're sure they not had an injection back there, because I'll see this sometimes.
Yeah, positive. I injected him. I inject lateral anyways, but I injected him.
Yeah, I'm concerned
So-
about that enough that I would do whatever I do to the cuff if it what however I'd fix the cuff or address the cuff, but I'd go and release the superscapular nerve.
You would. Okay.
Yeah, and there's several techniques for that. We can take care of that.
Okay. So here's his diagnostic arthroscopy here. Left shoulder, pretty inflamed. David, what do you do to measure these tears? How do you decide, you know, in terms of determining the thickness?
Yeah. Well, I go back to an older study from special surgery that looked at, it's just an anatomical study. Russ Warren did, it was years ago, and he just measured the distance between the articular margin and the cuff. And, you know, and based upon how the distance back from the biceps, you can predict within that group of patients the number of millimeters, and then you just basically divide that by a denominator, and that's my percentage. So it's, you know, so if I'm at, you know, so I just measure the distance between the articular margin and the cuff edge.
Gotcha. So anything different that you all do? That's pretty much what I do. I mean, I pretty much, if I say if I can stick that 5mm shaver in there, that's about 50%, you know. And so then I feel like if I can stick it between the articular margin and the tendon, that's pretty close. And I have a lower threshold if they're younger than if they're older.
I think the issue there of measurement, you know, so what I tell patients, it really depends on where the symptoms are coming from. If I'm sure the symptoms are coming from their partial cuff tear, then I basically tell them if I can stick an anchor in it, I'll fix it. And because the procedure, I'm not quite convinced that a debridement is going to work if your primary issue is just your rotator cuff and you've got no external impingement, you know, from the bursal side or internal impingements from the glenoid side. So if they truly are symptomatic from their cuff, and I'm there operating on them, then I would tend to, I personally do an in situ repair for any of the smaller ones, and then I'll do a takedown for a little bit more of the full thickness ones. But I tend towards in situ in general.
Yeah.
Pat, we got a question from the audience regarding
Okay.
in an asymptomatic pasta lesion. They talk about the Keener paper you brought up, a 1 and 5 year survival, 94 and 65 respectively. In your all clinical experience, are these appropriate numbers for the overhead athlete as well, or have you seen a much lower survivorship in that group? In other words,
Well, yeah, I'm not aware of any data on that. Keener's study, as pointed out here, is older patients, right? So I don't think we have anything to go off of. I can't tell you I've seen enough people out 5 and 10 years beyond to really get a good sense of natural history. Anybody else want to chime in there and have any different experience?
Yeah, there was one paper that showed that they tended to progress in the older overhead athlete. So it does tend to get worse over time. And I believe the number was, 30% of them would progress over time. I don't remember the exact number, but there does seem to, and they had a lower return to sport if they were older. So not only was it functionally worse for them, but, it tended to be a career-ending issue if they were in their 30s when they were caught. And that was from the Major League Baseball study. So it does tend to progress.
There's no Major League Baseball in Oregon. So, all right. So getting back here, David, I'm completely in support of what you said. I'm a big fan of trans tendon. This guy, though, I marked him, and what I often do just to mark the tear is to I'll take a spinal needle, and once I went back up top and went out, he actually had a bursal component here. So now when he's got this undersurface, oh, sorry about that. I felt like he had an undersurface component and a bursal surface component. He's got this kind of degeneration here. And so this is a rare patient for me that I felt like he was a takedown. And I elevated him here, and his tear pattern's a little interesting. I'll go back in and show you here. And so I go back in, and now he's got this kind of flap, as you can see here, almost as if his, you know, it's really his supra coming off on one side and the infra's wrapping around a bit. So I didn't want to take that area down, and I didn't really feel like I could do a takedown. I didn't really feel like I could do transtendon right where I wanted to, because he had that degenerative area on top as well. So I did I basically microfractured there, and then I passed inside to make sure I didn't capture the biceps, and did an inverted mattress suture here to bypass a bit, because right here is where I didn't feel like I could do that transtendon with that degeneration back there. I didn't want to create a big hole in the cuff, so I tried to grab some of that, and then to reinforce that degenerative tissue, I did a rip stop, passed a suture medial to that inverted suture, and then I went knotless lateral in this case. And then, just like Ed said, you know, I was concerned about that edema, and I felt like low risk, I could proceed and do a suprascapular nerve release and just eliminate that as a possibility. So I released his nerve. This is looking from a posterior portal to 70-degree scope. There's his nerve after we released it through a superior portal. So comments on that? How would anybody who manages differently in general, preference for takedown versus transtendon technique on the panel?
If I'm going
Sarah,
to do inside,
go ahead.
I 2-1, then I'll do it inside the glenohumeral joint, as opposed to doing anything on the bursal side. That looked like it was too big of a articular sided tear to do that. But if I take it down, I'm just going to do a 2-row 3-anchor repair and something like that. That's what I've done a little bit differently, but I think the end result's about the same. Do you do any steroid injections then after you do that nerve release? Do you put it there?
No, I've never done that. You do it at the time right at the time of the release?
Mm-hmm. Yeah.
I just get scared of the data from, I mean, elbows are a different animal, but you know, elbow arthroscopy, steroid injection at the time, raise the risk of infection. And I had a couple of patients early on. I did adhesive capsulitis, and I would inject them steroid, and it's like one of my only infections. So I've always been scared of injecting steroids right at the after procedure with a scope. You know.
Hey Pat.
Yeah, Bill.
What about would any of the panelists, or would you consider doing a bioinductive scaffold on this 65-year-old with an articular sided partial thickness rotator cuff tear?
I've only used that a few times, and had 2 of the 3 times the patients got pretty stiff. So I don't have a big experience with it. My experience hasn't been overwhelmingly positive, so I'm probably not the right one to ask about that. I probably wouldn't to answer your question, Bill. Right.
David, would you do anything different?
Well, I've been using some bioinductive patches lately. My indication is an insufficient but intact rotator cuff. So if I'm situated with a revision case where someone already had a much larger tear, and it was successfully covered the head with something, whatever that stuff is, and I don't feel like taking it down, I would put an inductive device on top, and we've been doing MRIs on those to see if it helps. So essentially, it needs to be completely thin. I probably wouldn't use it on an articular sided tear, but if we consider this tear just an ugly looking rotator cuff in an older person, I think I could make an argument to do that instead of taking down, because it's degenerative both on the top side and the bottom side. So maybe this does need some biology.
Well, just to be clear, the bioinductive scaffold was designed for articular sided partial thickness tear. So this was the actual case that it was designed for. Whether you believe in it or not, or whether you've used it enough to know if it's good or whatever, that's a whole nother discussion. But that was the original FDA indication for it. It's now being used in many other clinical scenarios, but interesting discussion.
Okay. Sarah, let's move on to your case here. I'll let you present. I'll advance along.
Okay, great. Thank you. So my case, this is a case I did last week, so it was very timely. A 62-year-old male who presented with the chief complaint of shoulder pain and weakness. He had sustained an acute injury in this past February. He was on the beach in Mexico and he was thrown down by a rogue wave, and he sustained a loss of consciousness as well as acute shoulder pain when he woke up. He had done physical therapy and anti-inflammatories with no significant relief. He had weakness with his overhead activity and disruption in sleep. So you can go ahead. On physical exam, he had significant pain at the bicep tendon. He had no pain at his AC joint or just at his greater tuberosity. He had full range of motion on his exam. He did have weakness and abduction. He had a positive near Hawkins and Jobe test. His subscap was okay on exam, and he had a positive speeds test as well. So we got an MRI, and the MRI, again, it's only a single shot, but it showed the interpretation from the radiologist is that he had a high grade partial thickness supraspinatus tear. Can you go on to the next one?
Yep, so some signal here and here.
Yeah. And on his axillary, you can tell his bicep tendon looks abnormal and it is subluxed out of the groove. And he also has this kind of atypical looking wavy appearance on his subscap. So I was concerned about that as well as the bicep. So when I entered, so we discussed his options, continuing conservative care versus surgery, but he was in a lot of pain and discomfort. So we decided to go to surgery. He'd already tried conservative care. And when I entered the joint, you can see he has this articular-sided pasta tear. I wasn't sure if it was full or articular at that point. His bicep tendon, it's a little difficult to see on that picture, but you can see it right there coming in next to the supraspinatus. And then you can see the cable at the top where this is kind of stepped back, and that's where the cable, the rotator cuff. All right, so you can go on. And this is a picture of the subscap up close, and you can see that he has avulsed the superior part of his subscap. There's maybe one little fiber hanging onto the lesser, but this subscap had this split in it, this V-like split, and this is part of the subscap tendon that is floating. So my approach to this case, once I saw that, step one, again, I knew he had bicep problems and planned on doing a bicep tenodesis. My preferred technique is an open subpec tenodesis. So I wanted to get the bicep out of the way. So I tagged it and I truncated it. My technique for that, I use a meniscal biter from the anterior portal to make a clean cut at the labral junction. And then I'll gently debride the superior labrum when I'm doing that. You can go on.
So Sarah,
yes.
I think what you're saying, I think was subtle, but I think really important for the fellows. I mean, because they're going to be getting in there and all of a sudden they're going to deal with this all at once. The order of steps. What do you got setting a multiple pathology, subscap, bicep, supra, maybe you're going to go at top. What are the keys to help you get through this case efficiently?
Yeah, definitely. I know when there's a subscap tear that it's going to take me a little bit longer. And I also know that it tends to swell because you're taking down some of that anterior capsule. So speed is of importance here. You don't want to linger. And so I start, once I kind of, diagnose what was going on, I want to move quickly. I get that bicep out of the way. I think it's important to get it out first. It makes the rest of your surgery much easier. So, and you don't even have to tag it. I like to tag it so I can find it when I'm exploring down in the subpec region, but you don't have to do that. That's an extra step and it just takes me a few seconds, but that's one thing you don't have to do, but I like to tag it so I can feel it later and be confident I'm pulling out the right structure.
So biceps out of the way, subscap, and then going supra.
That's right. So I address the bicep first, step two, then I address the subscap. And my technique for a subscap tear like that, I will, again, use my anterior cannula. I have a firm cannula in the front portal. And then I place I use suture tape, so it's a little bit larger diameter, and I'll place 2 sutures using a scorpion that will self-capture. And so you have your tails coming out anteriorly, and you create a mattress suture. And then I like to place it using a knotless anchor up front in the lesser tuberosity. And I think there's video on that, Pat. You can push. Is that one? Yeah, so that shows me, you can see there's the trocar for the anchor up front in the lesser tuberosity. I do not switch scopes. I do it through a 30-degree. You can improve your visualization if you're having trouble. And you can see I'm putting that down with the swivel lock up front. And I have a nice view. My bicep's out of the way, so I'm anchoring it pretty close to my bicipital groove.
Yeah.
And I've already placed my suture tape in the mattress fashion. Again, the limbs are out the front.
Any keys or landmarks with subscap?
You know, you can drive in and see it, look right over, you see the lesser tuberosity there. So, and I'll take my shaver right up front. You can take down some of that anterior capsule. Sometimes he was easy. I had a great view on him. Sometimes it's difficult. You guys know that. So it depends on it. With him, I think it was very simple, and that I had to take very little capsule down, and I could see.
Okay.
How many times do you find yourself, and this is for everyone, find yourself fixing the subscapularis versus saying, all right, I'm just going to do a tenodesis and therefore probably removing the deforming force of the biceps, cutting in between that intra-substance tear of the subscap. What's everyone on the call here, what's your threshold for repairing the subscap right there? That's a very nice.
Yeah, it's a great question. David, I'll let you go first.
I'm Spence, you beat me to that question because my has changed over the past couple of decades in the sense that I used to be much more aggressive about fixing the upper border subscap tears. So, but now I'm no longer. So if I think the pathology is within, if I think the pain generator is the biceps and the biceps is into the subscap, I will more commonly now leave the subscap alone. And I have not seen the tear progression that's been published. So in my, so it's very anecdotal, but I am gone to not fixing the subscap in most patients with these types of upper border subscap.
So David, if he has a full thickness upper subscap tear, so we'll say upper, less than upper 50%, you will just do the biceps tenodesis, or are you talking you only do that for a partial subscap tear, you'll just do the biceps tenodesis?
Yeah, it's these partial ones where the biceps subluxes and kind of gets into the subscap, and there's a few fibers connected, a few fibers not. If it's the upper, third, or if the upper third is disconnected, I'll fix that with an anchor. But if you have like these high-grade partials or these intra-substance tears, I'll just move the biceps.
Doesn't he, and if it's to sublux though, doesn't he have to have a tear that goes all the way through the upper portion of the subscap? Because I mean, when I see true bicep subluxation like this, I'm like, okay, by definition, the medial sling is disrupted. You're cutting in. He's got a full tear.
Yeah, they can cut out a slice or two early. Go ahead. Sorry, Ed.
I was gonna say, I mean, in my mind, I'm thinking that's an intra-substance tear. The most ventral portion is intact, the most dorsal portion is intact, and then there's a split in between, and the deforming force seems to be the biceps. And I've kind of changed like David, and so I think this is why I wanted to bring it up, is I thought it'd be good for when I first started. I was fixing a lot of these, and I was getting a lot of stiffness and external rotation. Then I really started thinking about it and following some of these people where I just did the biceps, and they really didn't have pain that I would expect to see with a subscap tear, meaning like a lift-off test that's painful, or abdominal compression test that's painful, or even throwing in a dominant arm. So then that started reaffirming, hey, I think I can leave some of these things alone.
If I see a full tear like that was, again, this is a full of a subscap there at the superior edge, and I'll fix that. I'm trying to, recreate that force couple. I think it's important to get it down. If it is partial or just tendinosis, I'm more likely to debride it. I agree with you and just take the bicep down, but that edge was completely off. So.
All right. So subscap's repaired here.
Yeah, there's my subscap. Okay, good. And we can move on. Everyone's excited about that. You can see it moving. Sorry.
No, it's nice repair though. It's low profile, knotless technique. I use a similar technique for
All right,
for
so
an upper tear. Go
yeah, so
ahead.
then I moved on, and now I'm addressing the supra. So I'm debriding that undersurface of the supra, taking down that degenerative tissue, and maybe his was somewhat traumatic as well with his history, but you know, at his age, potentially degenerative. So I'm working up there with the shaver, trying to determine, you know, how thick it is. And again, you can see my shaver has plenty of room there. You know, my shaver is a 4 millimeter, and I'll use that to determine the width. I use it as a measuring device, and you can see there the tissue. And he was about 8 millimeters, maybe a little more even. I think he was, yeah, I measured him at 12. So he had almost a full thickness tear right there. And he has
Okay.
really good tissue that's medial to that. And then I mark that area. So again, I want to tag that area so I can identify it on the other side. So I'll mark it with the PDS, nice bright blue suture. You can go on. And you can move on, it's fine, just me tagging it. All right, and now I'm in the subacromial space. So I've done a thorough bursectomy, I've taken out the soft tissue, and then I'm probing that area and trying to see if there's a full thickness tear, which there was not. I'm trying to kind of create one at this point because I've made the decision I'm gonna fix that. So I'll use my shaver and kind of dig into that area to see if I can create one. In him, I could not. So my preferred technique is actually to take it down. So I percutaneously put an 11 blade in, and I am completing the tear from the bursal side. And
Though this guy looks like he has some bursal sided pathology here already, or have you taken this down?
this is me taking it down. This is me,
But
yeah.
yeah, prior did he have? He looks like he has some wear right here. Or
He
did
did.
you
He
had
had a
already
little bit of wear. Yeah.
yeah.
He had a little bit of wear, so I was able to see the spot actually pretty easily, but it wasn't all the way through. So I did
But
have
if
to.
he But
Yeah.
if he's normal up top, you'd still, if you're going to do a repair, you're still you take down.
I still prefer to take down, and that's based more on my clinical experience. And we can talk about this. I'd love to hear your thoughts. But when I started in practice, I did them all transtendinous, and I found that they had a lot of significant pain and stiffness afterward. And maybe I was doing something wrong. I don't know. But then I started this technique, and they've done much better clinically in my hands. And so I have converted to converting tears. Okay. And that's why, just out of clinical.
And when you take down, you do a double row then, like,
yes.
like Ed was kind of talking about?
Yes. So then again, yeah, that's showing me doing the, or I'm sorry, I put an anchor then in for the medial row, and then I passed the limbs through, and then used again a knotless anchor for the lateral row. So I just repair it like I'm doing a typical rotator cuff repair.
Anything you do to make sure you're not over tensioning?
That's a great question. You know, I love to just look at the tear carefully. I learned this from Bill Levine, our president. He was my fellowship director, but looking at the tear from all directions. So I'll put the scope in laterally, and I see which way it wants to move. The tissue, I think, will tell you, and then try to approximate it right in that way. I think the device of our Scorpion device, or whichever your device that you use, is really nice, and that if you put it down to the hub, you know you're going to be right at where the medial row should be. You know, so you bury it to the hub and back up a millimeter or two, and you're going to have a 15 millimeter bridge there. So hopefully you're recreating the native footprint.
So I like to look too at the rotator cable, especially with pasta lesions. If you're going transtendon, or sometimes you can even go in and inside, because that cable, you got a nice cable there, and you know you want to make sure you're not over penetrating and bringing that over. If you can kind of get that cable just slightly medial to the articular margin where it was, is just another landmark you can use. How do you rehab this patient post-operatively? Spencer, do you rehab these partial tears any differently than your full thickness tears? And do you tell the patients anything differently about expectations?
Not really. I'm pretty, I just have them start doing pendulums for the first couple of weeks till the first visit, which is 2 or 3 weeks out. And a lot of them start doing some self-directed table slides. And I just let it pain be their guide. When they come back in, I start back in some formal therapy. massive tears. They're a little bit different, but
How long do you sling this guy or gal?
about 4 to 6 weeks.
David, what do you do? I lost your audio.
He's on mute. David, you're
Yeah, so I have a variety of different rehab protocols based upon tear size. So this one would end up in the group where I would rehab more quickly. Going back to what Sarah said, when I fix pastas, my concern is stiffness and I do a lot more, I guess, more intratendinous or transtendinous approach. I don't usually take down many of them.
Would anybody just mobilize this patient and no sling?
I wouldn't.
Yeah.
I'm
just curious.
You're still 6 weeks in a sling. It just depends on how quickly they're going to see the physical therapist.
I wouldn't do that either, but Alex Lederman had a study recently, small tears, full thickness, double row repairs, no mobilization versus sling, and they had no difference in re-tear rate, small numbers. But you guys hit this point here. There's a higher incidence of stiffness in this group. In Burkhardt's paper, 5% rate of stiffness, 13.5% in pasta tears. So definitely something you want to think about in terms of rehab. We want to get these patients moving earlier. So I'm going to try to move quickly on this one to get through. This is another patient who has a pasta tear. You see he's failed conservative treatment. We'll go up to his MRI.
Can I make one quick comment about the
Yeah,
stiffness?
please.
I don't want people to go home thinking that stiffness is always a problem with pastas. There's one
Yep.
study by Shin that compared prospectively two different groups. They did the takedown group and then they did the in situ repair group, and there was no difference in functional outcome. Stiffness was no different. Those 3 versus 2. And the big difference in outcomes was that the group that had the takedown, they had 8 failures and they all proceeded to full thickness tear, which makes sense because you take them down if they fail to full thickness tear. And what I noticed in my practice and what I changed, what I think has helped me reduce stiffness is when you're doing it percutaneously and transtendinously, the distance between the sutures that you pass, so that bursal side, the amount of bursal side intact cuff that you sew down is going to dictate how stiff it's going to be. So if you end up at the underside of your partial tear and you're traversing 3 centimeters of bursal side intended to get there, then they're going to get very, very stiff. But if you're going to end up 1 centimeter away and you traverse only 1 centimeter, then stiffness will be 2.
I completely agree with you, David.
Yeah, it's a
Go
great
ahead.
point. That's why I don't like doing the transtendinous repair. I'll just do it all inside the glenohumeral joint. So place an anchor percutaneously and pass everything inside the glenohumeral joint. So you're just tying down the articular layer. So that's mitigated it for me, the stiffness.
So I'm gonna skip up on this guy because we've talked about conservative treatment, but you guys both make great points. There's many ways to do this. I like David, I'm a big trans tendon actually, but I think the key, like he talked about, is you got to be very careful with when you are placing these sutures. So we said this was a 59 individual. He's got a subscap there. I'm going through the bicipital groove. So just like Sarah's case, you'll have to look for your associated pathology. So what I'll do here is make sure just the order of steps again are important. We got to get the biceps out of the way. I'm just going to skip this so we can kind of move to some other stuff here. So I get the biceps out of the way here. I'll repair his subscap first. I did the same kind of thing Sarah did here, a knotless technique. I do an onlay with the biceps at the same time. That's dealer's choice, not the subject of what we're talking about here, but simultaneous tenodesis and cuff repair. And then I like to do a trans tendon repair. David brought up some really great points. This is just, oops, sorry, I got to jump forward one more slide. Oh, you already hit this. Do the results differ in terms of the outcomes? No, the studies show that they don't really differ. We know biomechanically trans tendon is better, but clinically no difference in the literature. And you talked about this study, you nailed this. They were a little slower to get back their motion in trans tendon, but they did get them back and no difference. And I brought this point up thinking about the rotator cable. So we'll jump up to actually showing the technique. I'm sorry, I missed that one before. Let me see if I can get his video back for you in terms of the actual repair. Okay, right here. So we have his pasta lesion. I like to go transtendon, but this gentleman, I had opened up above the bicep. So I have a cannula in the anterior supralateral portal. So I placed a knotless soft anchor. It's a 2-6 anchor. And it's kind of a hybrid because I'm going to shuttle through here because I have this hole from where I access the biceps. So I shuttled through with the scorpion. And then the posterior suture to that, now I got to go through the infraspinatus. I placed transtendon, use a spinal needle as a guide. I like to get my angle, come right straight down against the articular margin, not come over too far medial or lateral, just using your anatomic landmarks to make sure you get appropriate tension. Then I placed a guide through percutaneously. And this again is a 2-6 anchor, so we're making a relatively small hole in the cuff. And there's our two suture sets. And this is you can tie knots here between the two. This is a knotless type of anchor. So I'm going to link the two anchors because this is going to shuttle into itself. So I have my repair stitch in the front. It's going to link to my shuttling suture in the back. So it'll bring that suture down into the knotless mechanism. So the final result is that I'll get a medial mattress type of technique. Here you'll see this here. You got I brought the anterior down to the posterior. Now I'm bringing the posterior down to the anterior. So those are our mattress sutures. You go back inside and it's been brought down. And I think if you look back up top at the final view here, careful not to have over tensioned him here. I have these patients move right away in terms of table slides and passive ER. So I think there we respected his anatomy, knotless repair. But lots of different ways to treat these. And I just did this about the results differing. So let's move on to some different pathology in our final few moments here. I'll skip this one. This is another transtendon. So we talked a lot of time about pasta. We have to recognize that there's other tear patterns. Any difference in threshold for repair, bursal versus partial articular sided? You guys have a lower threshold, same threshold, higher threshold for repair?
I think
Treat them the same?
ones are more symptomatic. I think they have more pain, but I don't really have a different threshold. I've got a different technique. I think this is what you were talking about, Pat, with that. If you can go back to that schematic that you had there of the 3 tears.
Mm-hmm.
Yeah, so that intrasubstance tear, that was the first case that you presented was an intrasubstance tear. So we just submitted a paper to AJSN looking at 25 cases that we did a PRP injection for, and then 25 that I took that bursal side down and just repaired it with inverted mattress tapes taken down to a lateral row anchor. And they did equally as well. And the PRP patients actually got better quicker. You have to take that a little bit of grain of salt because the rehab was designed to be a little bit quicker with the PRP patients. But clinically, they did well. We had one post-op MR just because she wanted to see it and it had healed. But the PRP for an intrasubstance tear really works well because the material stays in the pocket there. And we thought it'd be a great tear pattern for that. We've used it in tendinopathy. I've not used it in bursal-sided tears nor articular-sided tears.
Did you randomize, Ed, to repair versus PRP?
Yeah. We gave, it was a cohort of patients that I had repaired previously, but we gave the ones that we studied the option where you can either do PRP or repair. Don't know if the PRP is going to work, and so the patients chose to try it. So there's definitely some bias to it, but as is there for all studies, but at least it showed us that it's a viable option. It heals a little bit more quickly. They usually turn the corner at around 8 weeks, 6 to 8 weeks. They're uncomfortable for the first week, very uncomfortable for the first week, but then they start turning the corner. And usually about 3 months out, they're doing pretty well. So they, on average, got better about 3 weeks quicker than the repairs did. So just something else for the fellows to consider. Just consider when you're looking at these things, there is a role for PRP and there's a role for biologics like Bill was saying, in those the inductive scaffolds. So,
Gus, what do you think? Do we need to stop, or can we?
Yeah, we're at 10 o'clock. Maybe
Okay.
summary statements, little take home, and then we'll let everybody go.
Yeah. All right. So apologize for not getting to these other types of tears, but I think we kind of covered the approach and treatment. David, any final thoughts on partial tears for guiding the fellows?
I think the most important thing is to listen to your patient, understand the pathology, and understand what your patient's goals are. So if you understand the pathology, the treatment is going to be much more simple than saying, I'm always going to do this or I'm always going to do that. Some pathology you may need to treat more aggressively, surgically with repairing. Other pathology, a small bursal tear, that may not be the issue where you need to fix it with an anchor, maybe a decompression. So listen to your patient, get a partnership with your patient, and they'll be happy.
Sarah and Ed, how about just guidance for what's your single piece of advice for starting practice as these fellows are going to be starting?
All right.
Yeah,
Keys to success.
Go ahead, Ed.
Go ahead, Sarah. You go first.
No, I would just say, remember that these are two different animals here. You've got the young athlete with a partial thickness rotator cuff tear. Is a completely different situation than a 62-year-old with a partial rotator cuff tear. And you're going to treat them differently and think about them differently. Be very hesitant in operating on a young overhead athlete. Try to exhaust conservative measures, send them back again. If you notice they have that GERD pattern, where they've got an internal rotation deficit, do not make a clinical decision until their range of motion has resolved. So that's my advice.
Great. Ed, anything to add?
Yeah. Look at the MRIs critically and try to predict what you're going to see, and make sure you learn from that in the OR. Please check the passive range of motion when they're asleep. Compare from side to side. I think there's a fair number of POSTA tears that I've seen that have been referred to me that got really, really stiff. And if you look back at their intraoperative pictures, there was a ton of synovitis. The patient really had a frozen shoulder from the get-go. Probably should have been picked up examination under anesthesia. But certainly if you miss it on the examination under anesthesia, say that it's subtle and it's just a loss of internal rotation at 90 degrees, at least have your antenna up. And then when you get in there and you look arthroscopically and synovitis, stop. Probably do not repair that. Give some consideration to looking at the glenohumeral joint just with air. So I'll insufflate the joint with 60 pp's of air and blow it up and be able to see the joint very nicely. It gives you an idea of where you may need to stick your portals if you're going to fix a POSTA tear before you stick your portals in there. So look at it with air, and then you can get your portals in there. So those are just a few portals.
Okay, I love that comment about stiffness. I think you nailed kind of why a lot of this happens. I actually think is aside from the repair technique. Want to thank everybody for joining us, and thanks again to the designers of this, Dr. Mizaka and Gupta, for letting us present tonight. So we'll conclude there.
Great job, everybody. Thank you.
All right, thank you.
Have a good night.
Buddy.
Guys, good night.
Right.